Hello and welcome to this learning module. Today we'll provide an overview of injuries to the chest. This video is intended to supplement any readings or coursework assigned by your instructor. The objectives for this learning module are: number 1, identify anatomic structures commonly injured by penetrating and blunt chest trauma. Number 2, assess a patient with a thoracic injury. And number 3, provide pre-hospital care to a victim with a chest injury. The image on the left of the screen illustrates the thoracic cage or rib cage that protects the organs of the chest cavity. Vital organs, including the heart and lungs, sit in the thoracic cavity, and blunt or penetrating trauma to this part of the body can cause life-threatening conditions. The mediastinal area that lies beneath the sternum includes the trachea, heart, vena cava, and aorta. The vena cava, the aorta, and the pulmonary arteries and veins comprise the great vessels of the human body. Injury to one or more of these vessels can lead to significant internal hemorrhage. The diaphragm sits at the bottom of the thoracic cavity and separates the thoracic cavity and the abdominal cavity. When inhaling, the diaphragm contracts and moves downward to flatten and increase the space in the chest cavity. At the same time, the intercostal muscles contract and pull the rib cage upward and outward to enlarge the chest cavity. These simultaneous contractions increase the volume of the thoracic cavity, which lowers the pressure compared to the atmospheric pressure outside. This causes air to rush into the thoracic cavity. As the diaphragm and intercostal muscles relax, the air volume in the lungs is compressed, the intrathoracic pressure increases to a point that is higher than the external atmospheric pressure, and air is exhaled from the lungs. As we just mentioned, the chest contains several large blood vessels, including the inferior and superior vena cavae, the pulmonary arteries and veins, and the aorta with its major branches that distribute blood throughout the body. Injury to any of these vessels may be accompanied by a massive and rapidly fatal hemorrhage. Patients with a chest wound that shows signs of shock but no significant bleeding may have an injury to one or more of these vessels. In the image here, we see some of the potential mechanisms of injury that can cause thoracic trauma and the subsequent injuries each mechanism can lead to. Chest injuries may not be as obvious as other types of traumatic injury, so a thorough assessment is necessary. When assessing a patient for chest trauma, EMTs must inspect, palpate, and auscultate for injuries. The EMT should inspect the patient's skin color and condition for signs of shock, which might include pallor and/or cyanosis, along with diaphoresis or sweating. The EMT should also look for equal and adequate chest rise and fall with each breath. The trachea should be observed to ensure it is midline and not deviated to either side. The chest should be inspected for any deformity, contusions, abrasions, penetrating wounds, burns, tenderness, lacerations, or swelling, also referred to as DCAP BTLS injuries. If any wounds are identified, we must consider the possibility of trauma to underlying organs. After inspecting for injuries, the provider should put hands on the patient to palpate for abnormalities or injury. By palpating the chest wall, we can better assess for tenderness, deformity, crepitus, which is a grating sound or sensation that occurs when the bones or cartilage rub together, and subcutaneous emphysema, which is caused by air in the tissue under the skin. Subcutaneous emphysema feels like the sensation you get when you crunch crispy puffed rice cereal. When palpating the chest wall, the EMT should feel for the presence of unequal chest rise and fall, or paradoxical chest wall movement, which is when the chest wall moves opposite to its usual direction during breathing. The last portion of the BLS chest assessment includes auscultating bilateral breath sounds using a stethoscope placed at the apices, mid-thorax, and bases to ensure they are present and equal. The EMT should also make note of any abnormal lung sounds, including wheezing or crackles. Blunt thoracic trauma describes physical trauma due to a forceful impact without penetration of the body's surface. Blunt force trauma to the chest includes damage caused by direct force, such as a fist or a bat during an assault, acceleration or deceleration and shearing forces from a vehicle crash, compression injury from a heavy object falling on the chest, and blast injuries. In the image on the left, we see that blunt trauma can lead to rib fractures. When two or more ribs are broken in two or more areas, a flail chest can develop. Flailed chest can interfere with the victim's breathing and may lead to respiratory failure if not properly treated. Penetrating trauma is caused by an object puncturing the chest wall. This includes gunshot wounds, stab wounds, and impaled objects. Penetrating trauma is associated with higher mortality than blunt trauma. Penetrating chest injuries can involve any of the vital organs that lie in the chest cavity. Open chest wounds, like the gunshot wound seen in the image on the right, can interfere with the negative pressure that is necessary for inhalation. Prompt recognition and proper treatment is needed for the patient to have a good outcome. A pneumothorax results from a collection of air in the pleural space, which results in the collapse of the lung on the affected side. This image illustrates how air can leak from an injured lung and cause the air in the thoracic cavity to compress the lung and prevent full inflation. A simple pneumothorax, like the one in this image, can be caused by medical issues like a bleb or weakened area of lung tissue, or by blunt trauma to the chest. By definition, a simple pneumothorax does not result in major changes to the victim's cardiac physiology. A simple pneumothorax can progress to a tension pneumothorax, which can become a life-threatening situation. Signs and symptoms of a simple pneumothorax include difficulty breathing, chest pain that worsens with deep inspiration, tachypnea, and decreased lung sounds on the affected side. Patient care includes administration of supplemental oxygen and close monitoring of vital signs, lung sounds, and pulse oximetry for signs of deterioration. A tension pneumothorax is an immediate life-threatening situation. As we see in the image on the left, the pressure from the air in the chest cavity collapses the lung on the affected side and begins to shift towards the other side of the chest, compressing the lung on the unaffected side. Additionally, the heart and great vessels can be compressed, leading to a state of hypoperfusion or shock. Signs and symptoms of a tension pneumothorax include extreme dyspnea, absent lung sounds on the affected side, and signs of shock including increased heart rate and respiratory rate. Other signs and symptoms may include jugular vein distension, tracheal shifting, and diminished lung sounds on the unaffected side of the chest wall. A tension pneumothorax is an advanced life support call. The paramedic will perform a needle chest decompression, illustrated in the image on the right. A large needle is inserted on the affected side, which allows the trapped air to vent through the needle, allowing the injured lung to reinflate. This procedure is a temporary measure, and definitive care will include the insertion of a chest tube at the trauma center. An open pneumothorax is also known as a sucking chest wound. This is caused by penetrating trauma to the chest that allows air to enter the pleural space through the chest wall. As the air enters the chest wall, it compresses the lung on the injured side. Signs and symptoms of an open pneumothorax are the same as those we just discussed for a simple and tension pneumothorax, with the exception that you will see an opening into the chest wall. As the patient breathes, you may hear air hissing and see bubbling of blood at the injury site. It's important to note that penetrating injury to the anterior, posterior, or lateral chest wall can all cause an open pneumothorax, so a thorough assessment must be completed. Immediate treatment for an open pneumothorax includes placing your gloved hand over the wound to prevent air from entering through the chest wall into the pleural space. Next, we need to cover the wound with an occlusive dressing that will seal the wound and prevent air from entering. This can include petroleum jelly gauze, aluminum foil, or a piece of plastic. Ideally, we want to tape down 3 sides of the occlusive dressing as seen in the image to the right. In this image, the EMT applied a piece of sterile gauze and covered it on 3 sides with a transparent occlusive dressing. You're probably wondering why we only tape 3 sides. Well, when the patient inhales, the occlusive dressing will pull down against the wound, preventing air from entering the pleural cavity. As the patient exhales, any air that entered the pleural cavity through the wound will exit the chest wall through the side of the dressing that's not taped down. Be sure to dry the wound site so the dressing will adhere to the chest wall. It's very important to monitor a patient's lung sounds very closely after the application of an occlusive dressing. It's possible that air can still enter the pleural space through a punctured lung, which can cause a tension pneumothorax. If diminished breath sounds are heard on the affected side or the patient develops increasing dyspnea, we want to temporarily lift the occlusive dressing to burp the wound and allow the air in the chest cavity to vent through the open wound. On the left, we see a manufactured occlusive dressing called a vented chest seal that can be used in the pre-hospital setting. The chest seal should be placed with the one-way valve centered over the open wound. The valve allows air to exit but not enter the wound. A hemothorax results from bleeding within the pleural space. This can be caused by blunt or penetrating trauma. The blood in the chest cavity will compress the lung and prevent it from expanding, much like air from a pneumothorax would. The resulting blood loss into the chest cavity can result in profound shock. Signs and symptoms include respiratory distress, absent breath sounds on the affected side, and hemoptysis, or coughing up bloody, frothy sputum. In this image, we see a post-mortem view of coagulated blood in the chest cavity. It's easy to see how a hemothorax can lead to a collapse of the victim's lung tissue. A hemopneumothorax is a combination of blood and air in the pleural space. If you percussed or tapped on the affected side of the chest wall with 2 fingers on a patient with a hemothorax, it would feel like a dull thud. If you were to percuss the chest of a patient with a tension pneumothorax, the air inside the chest would make it feel like the vibrations felt when tapping a drum. This is one way that providers can differentiate a hemothorax from a pneumothorax. Pericardial tamponade, also called cardiac tamponade, occurs when blunt or penetrating trauma to the heart causes bleeding into the fibrous pericardial sac that surrounds the heart. The term tamponade refers to the compression of the heart muscle. Normally, the pericardial sac contains about 50 milliliters of pericardial fluid, which serves as a lubricant to prevent friction when the heart beats. This is illustrated on the left. When cardiac tamponade happens, the pericardial sac can expand upwards to 200 milliliters or more, depending upon how quickly the bleeding occurs. This is illustrated on the right. Compression of the ventricles results in inadequate ventricular filling and causes a reduction in cardiac output. The 3 characteristic signs of cardiac tamponade are known as Beck's triad, and they include a drop in blood pressure accompanied by a narrowing pulse pressure, the development of jugular vein distension, and muffled or faint heart sounds upon chest auscultation. Other signs and symptoms of cardiac tamponade include unexplained signs of shock or hypoperfusion, tachycardia, or tachypnea. You might also detect a radial pulse that diminishes as the patient inhales. This is referred to as pulsus paradoxus. Prehospital management of cardiac tamponade includes treating the patient for shock and rapid ALS transport to the closest receiving facility. Definitive care for this life-threatening emergency is a pericardiocentesis, which involves inserting a needle under the rib cage and into the pericardial sac to extract the blood. Unfortunately, this is not a skill included in most paramedics' scope of practice. Rib injuries are common with blunt trauma to the chest. Rib injuries are painful and can cause discomfort, especially during inhalation. This may cause some shortness of breath for the patient. The patient may also present with pain, swelling, and deformity over the injury site. You may feel crepitus upon palpation of the injury site. The patient will often complain of increased pain in the region of the injury site during inhalation. The patient may also present with guarding of the injury site by using their arm to splint the injured area. Treatment of a rib injury includes placing the victim in a position of comfort on the stretcher and administration of supplemental oxygen for dyspnea. Placing the patient's arm into a sling on the injured side may relieve some of the discomfort associated with rib fractures. This technique is illustrated in the image on the right. Securing the sling to the chest with a folded triangular bandage known as a swath helps to further stabilize the injury site. As I mentioned earlier, a flail chest results when 2 or more adjacent ribs are broken in 2 or more places along their length. The unstable fracture site is called the flail segment. The image on the right illustrates how paradoxical chest wall movement happens with a flail chest. During inhalation, the chest wall expands but the flail segment moves inward. During exhalation, the chest wall retracts and the flail segment moves outward. The pressure that drives the air out of the contracting chest is what pushes the unstable flail segment outward during exhalation. This causes the potential for damage to the heart, lungs, and great vessels. If the patient is breathing adequately on their own, we should provide supplemental oxygen to a saturation of 94%. Continuous positive airway pressure, or CPAP, can be considered for patients who are conscious and able to maintain their airway. For patients having difficulty maintaining adequate oxygenation or who are experiencing extreme difficulty breathing, we need to assist ventilations with the bag valve mask connected to high-flow oxygen as seen in the image on the left. Paramedics can initiate IV access, manage pain, and consider endotracheal intubation if required. Attempts to stabilize or splint the flailed chest should not be attempted, as it delays transport, may further compromise chest wall motion, and may impair ventilatory efforts. Immediate transport to a trauma facility is required. A pulmonary contusion or bruising of the lung tissue is usually caused by blunt trauma. Bleeding occurs in the lung tissue in and around the alveoli. As a result, gas exchange becomes impaired, which leads to hypoxia. The amount of respiratory distress the patient experiences will depend upon the amount of damaged lung tissue. In addition to dyspnea, the patient may present with cyanosis, pain, swelling, or deformity at the injury site. Much like a pulmonary contusion, a cardiac contusion is associated with blunt trauma to the chest wall around the heart. A resulting bruise to the heart muscle will develop. A cardiac contusion can cause a rupture of the heart muscle and/or disruption in the electrical conduction system. Signs and symptoms of a cardiac contusion include chest pain at the injury site, external signs of blunt trauma to the chest wall, deformity to the chest wall, tachycardia, and an irregular heart rate. Traumatic asphyxia occurs when the thorax is compressed, forcing blood from the heart back through the veins into the neck and head. It's also known as crush asphyxia. A victim who has experienced traumatic asphyxia will generally present with bluish-red to bluish-black discoloration of the head, neck, and upper thorax above the level of the injury. Assessment may also reveal subconjunctival hemorrhage, petechiae or small reddish-purple spots on the skin, and neurological symptoms. The term asphyxia is often associated with a fatal outcome, but these patients often have a good prognosis with appropriate trauma care. Pre-hospital care for pulmonary contusion, cardiac contusion, and traumatic asphyxia includes treating any symptoms that may be present, appropriate airway management, and rapid ALS transport to a trauma center. Commotio cordis is a sudden cardiac arrest caused from a blow to the left side of the chest during a narrow window in the cardiac cycle. In the image on the right, we see the outline of the heart in red. The sensitive zone for mechanical induction of heart rhythm disturbances lies in the anterior chest area over the heart. The image on the left illustrates the extremely narrow window of commotio cordis risk during the ventricular repolarization phase of the cardiac cycle. While rare, commotio cordis commonly occurs during amateur sporting events when the victim is struck by a baseball, softball, lacrosse ball, hockey puck, or a blow from a karate competition. In fact, if you search videos of commotio cordis on the internet, you will likely find a video from a karate competition where a competitor suffered commotio cordis from a punch to the chest. Prompt CPR, application of the AED, advanced life support, and rapid transport is key in managing a victim of commotio cordis. In the last slide here, I'd like to talk about some advanced concepts. Insertion of a needle or angiocatheter into the pleural space on the affected side of a tension pneumothorax will help to change it to an open pneumothorax, which will allow trapped air to escape on exhalation. There are two sites where paramedics can perform this procedure. Number one, the second intercostal space between the second and third rib in the midclavicular line on the affected side of the chest, or number two, at the fifth intercostal space between the fifth and sixth rib along the anterior axillary line on the affected side of the chest. The angiocath should be placed above the lower rib in the intercostal space to avoid damaging the neurovascular bundle that's located underneath the upper rib, as seen in the image here. The second intercostal space is the more common site used by paramedics because it's usually easier to access. The thicker chest wall at this location may result in the inability of the catheter to actually get into the thoracic cavity and may cause kinking of the catheter during patient movement or transport. The preferred site is the fifth intercostal space along the anterior axillary line because it's safer, the chest wall is thinner, and higher success rates have been reported here. Additionally, evidence suggests that the needle chest decompressions performed here are more stable and less likely to become dislodged during movement or transport. The catheter should be a large bore 10 to 16 gauge IV needle that is at least 3.5 inches in length. The paramedic will advance the catheter until a rush of air is heard or felt. Once decompression is achieved, the needle is removed and the catheter should be taped in place to prevent accidental dislodgement. Since the catheter diameter is very small compared to the patient's airway, it's not likely that air movement through the catheter will compromise the patient's ventilatory status during inhalation. Current trauma standards no longer recommend taking the time to apply a one-way valve to the catheter. The patient's vital signs, oxygen saturation, and end-tidal carbon dioxide levels should be continuously monitored, as should lung sounds, to ensure there is no dislodgement or kinking of the catheter. This brings us to the end of this presentation. Here we see the learning objectives for this module. Can you demonstrate each of these objectives? If not, please consider going back to review any content that you struggled with. Thank you for watching this learning module.